Hi, everyone. I'm Lynn Videcka, the Dean of the School of Social Work, and we're going to be very informal this afternoon. And I want to invite everyone to please help yourself to some snacks and a beverage of your choice. And we're not going to hold the reception till afterwards. We might as well enjoy it now. So I think I will begin the introduction of Dr. Liliana Goldín. I'm really pleased and honored that she could join us today and tell us about her work, which has spanned several decades in Guatemala. Dr. Goldin received her PhD in 1986 from the University at Albany, State University of New York. We first knew each other from afar in Albany when we both worked there. She continued as an assistant professor after she received her degree and worked at Albany till 2004. At that, 2004. At that time, she moved to Florida International University, where she was professor of anthropology and director of the doctoral program in global and social cultural studies. And she worked there till 2011. Then starting in 2011, we had the true privilege of, I had the true privilege of working directly with Dr. Goldin when she joined the Silver School of Social Work faculty at New York University. And that's where I got to know her work, and she got the experience. Probably she didn't plan it early in her career of moving from working in her field, anthropology, to working in the field of social work as a faculty member. So Dr. Goldin has, a long history of funding from the National Science Foundation. Her book is entitled Global Maya, Work and Ideology in Rural Guatemala. And indeed, much of her work has focused on the role of work for women in rural Guatemala. But today she will be talking about her newest facet of her work. The talk's entitled A Sustainable Intervention to Improve Adherence to Type 2 Diabetes Protocol Among Indigenous People of Guatemala. So with no further ado, I will bring you Dr. Liliana Goldin. And I just will let everyone know we'll be taping this because there's several people who wanted to join us today who couldn't be here. So the lecture will be available via tape afterwards. Okay, Dr. Goldin, please, let's give her a hand.
Can you hear me okay? Okay, so what I thought I would do, I've been working in Guatemala for way too many years, and I had 3 areas of research, and because most people today don't know me and don't know my work, I want to spend it's 4:10, about less than 10 minutes to tell you about other projects in Guatemala, and then move on to this one. Um, my earlier work, and it's always been related to the economy, economic development, had 2 questions. One was an applied question. Why are some communities in the Western Highlands, where I was working, doing better than other communities? And the other one was a theoretical question. What is the relationship between practice, that is productive activities, and economic ideology or attitudes towards the economy? As an anthropologist, we always want to know what makes us, the kind of people we are, and how do we shape, if we shape the way we think in relation to whatever our productive activity is or not. This study and several studies that I did since I started culminated with a book that Lynn mentioned, Global Maya. In Global Maya, what I do is I compare 4 forms of production that are quite different, and I explore the attitudes towards the economy that people have in each form of production. we don't have time to go over the book, but basically I find that their attitudes toward the economy or economic ideology are very different in the context of each form of praxis, confirming, if you want, in a dialectical mode, that we do form ourselves in practice. That is what we do, where we grow up, how do we make a living, that defines the way we think about the world. So that works in as I say, dialectical form and an interesting form. The first study was on intensification of production in San Pedro Almolonga, which is the couple of pictures you've seen, where they do a direct export of vegetables. They grow amazing vegetables, and this is outside their market. The second project, I don't want to spend, I could talk about this for a very long time. So the second project was in a different kind of town, San Francisco El Alto, the 7,000 feet community where they dedicate themselves to petty industrial production, where you find home workshops, like the one you're seeing. We call these cottage industries, people working at home, producing, in this case, Western style clothes. This lady, I lived with her family, she's making shirts. Someone, a petty capitalist, brought her shirts to her house and she assembles them at home. I put this is the bed where I was sleeping, but I put the picture because in the back you see there's a picture, photograph of Houston, where several members of the family had migrated and returned. They weren't very successful, they couldn't find jobs, and they had pretty horrible experiences in crossing the desert. The third form of production is non-traditional agricultural exports. These are the production of the vegetables that we buy in our markets here in the US and in Europe. The very strict conditions for export here, they're literally removing pests from the vegetables so that once they pack them, the people at customs don't find, even though they will be frozen, but that people in customs won't find anything that is questionable to admit them to the United States. And the last form of production I call Maya maquilas. Maquilas are export processing factories that started opening in Mexico. Maquila factories opened in the 1970s. In Guatemala, it was in the 1980s. In the 1980s, I started working with maquila factories in the early 90s. At that time, the workers were about 12, 13 years old. You can see here a picture of one of the early focus groups that I organized at the beginning, before I got started with the research, to find out a little bit about the factories and the workers. We're just passing around a tape recorder. This is a group with men because in Guatemala, unlike other parts of the world, there's quite a bit of men that work in the factories as well. With time, and because of complaints coming from the United States, and you may be familiar with some of those, the age of workers increased. People in the United States complained that the workers that were making our clothes were too young, that we were literally exploiting minors in the making of our clothes. So the Guatemala established 18 years old as the age for maquila workers. Of course, none of the workers are still, some are 18 and older, but many are still 15, 16. They just use IDs from sisters and cousins, but they never, you don't see them as young as you see them here, but young women find the work in the maquilas a very good job. It pays better than agricultural work. And other than that constituted my work on labor issues and economic issues in rural areas. The second stream of my research was in urban Guatemala, in peripheral areas or shanty towns of Guatemala, where the poorest people migrate to, homeless people migrate to, when nobody was able to, relatives, they go to Guatemala City to live with relatives, but the relatives say, we can't have you here more than a week. So they they find a place in the surroundings of Guatemala City. And of course, in the pictures, you see different levels of development, and because there's several neighborhoods. There we compared a neighborhood that had an NGO for women to provide work and daycare and many other services with a neighborhood that didn't have the NGO, to see if how effective was the NGO in providing work, and how the possibilities for similar NGOs to develop and establish themselves in other. They were created by local women and run by local women. And you'll see they had a clinic and they had family planning. The lady with a long ponytail, the second to the left, was the first person. She was a nurse. She was the person that had the idea of creating the NGO, but after a few years of running it, she completely left it to the indigenous women that to run it by themselves, and they ran it as a cooperative, and they're still running and it's still doing well. They just added a bakery to the many activities that they have there. So here we come then to today's project presentation about adherence to type 2 diabetes among Maya women of Guatemala. The picture you see is of Hospital Regional de Quetzaltenango, the largest public hospital in Quetzaltenango. We were able to get their support to, oops, wrong direction. We were able to get their support to run a study there. So in Guatemala, there are about 1 million patients with type 2 diabetes, primary cause of mortality for women with chronic diseases. Latin America, the cost is over $65 billion. I mean, it's definitely a global epidemic. We all know someone that has diabetes. It's much problematic in Guatemala among indigenous peoples, because they don't always go to see regular doctors. They don't really trust regular doctors very much. They sometimes live far from the town hospitals or city hospitals, and they tend to go to the hospital when it's already late in when the disease is already, sometimes they're blind, sometimes they lost a foot, or they had a terrible infection, when the disease is really running havoc with their lives. What are factors associated with adherence? This is a very quick lead review that I'm going to present to you. There's lack of services. We want simple treatments, but diabetes, if you're familiar with it, it's not simple to address. Usually has 4 elements. You have to change your diet, you have to exercise, you have to do regular blood tests, and also you have to take medication for the rest of your life. That is not easy for anybody, especially indigenous peoples, to digest, if you want. Communication strategies with medical personnel can help or can deter adherence. In Guatemala, a majority of the medical community speak Spanish, and the indigenous communities speak some Spanish, especially men speak Spanish, but women are not always fluent, especially older women speak Maya languages, one of 22 non-mutually communicable Maya languages. The more we know that the more patients know about their disease, the more they adhere, more knowledge, more self-control, more self-efficacy. Cultural dissonance between local beliefs and medical community tends to drive to lower adherence. Even when there is motivation to adhere to treatment, there's so many barriers for people to do what they need to do. They either don't have money to buy the medicines, they don't have time, the family won't support them. Um, Many get depressed when they get the diagnosis and realize that they have to change their lifestyle. Factors associated are family situation. Of course, the more support, the more adherence, social support. It's not an individual problem, it's a family and community problem. And of course, gender, because men are more protective than women in the families. Women take care of men in the family. That's their job. They will prepare their meals. And if the doctor tells a man you have to eat in a certain way, the wife will do whatever the doctor said to do. But if it is her that needs to take care of herself, the family won't support a change in their diets. Most effective interventions tend to be complex, costly, and their effects tend to be very modest. So, and of course, it's always better to work with groups and individuals towards education. So I put this picture not so much to show you a picture of me and Elisa Liliana Schiap, which is a woman from Almolonga that became the first doctor in her community. I lived with her family the year before she was born. And then I established a relationship with her. I always visited with her. And sometime around 2010, we met with her in Quetzaltenango, and she asked me if I would help her to develop some program or something to reduce diabetes among the indigenous communities. She had just completed her medical, they write a thesis. I don't think they do that in the US, but they write a thesis in their graduation year. And her thesis had been on diabetes among indigenous peoples with examples from her own community of Almolonga. When she came to me, again, you've seen the work that I had been doing, well, always in economic anthropology and economic development. The first thing I said is, I don't know anything about diabetes, but I will try to learn something and I will figure out if there's something that we can do. And that's exactly what we did. I studied, I talked to Jim Jackard, who is an expert in intervention research and communications. And I talked to my team in Guatemala about what we could do. And we designed a pilot study. We based the pilot study with women from this hospital. What you're seeing here is one of the two waiting rooms in the hospital. People wait 3-4 hours to see a doctor. They arrive very early in the morning when they want to see a doctor, maybe about 6 a.m., and the doctors won't start seeing them until around 8:30, and then they just spend many, many hours in the hospital. This is right outside the hospital where family is waiting. So adherence is sought in the context of poverty, ethnicity, language, education, and gender, as you probably know. And there's many structural factors that are very difficult to change. We would love to be able, there's great discrimination against indigenous peoples in Guatemala. There's great poverty, although there's differentiation. They're not all equally poor. There's some wealthy Indians and poor Indians, but overall they are poorer than Latino and white populations. So what we tried to do was to identify immediate determinants of adherence that would interfere with effective treatment rather than structural factors that are led by policy, right? If you're working on policy, you might be able to change and affect overall conditions in the communities. So we conducted in-depth interviews, 29 female patients with diabetes, 5 physicians. Um, Interviews lasted an hour. We obtained general demographic data on the patients, and we asked them all sort of questions about how they understood their disease, what were their symptoms, what did the doctors tell them, what did they think that should be different in their care, support barriers, lots of questions. And we also asked patients and doctors how would they improve the treatment of patients. What else could they do differently? This is just a little bit of the description of this small sample, mean age of 52, 4 years of education, half Catholic, half evangelical, mostly Maya populations. So we analyze the data using Atlas TI. I don't know if you conduct qualitative research, you might be familiar with qualitative programs. We had a lot of information in only 30 interviews, but there was a lot of information. And we analyzed the main themes that people found and the sub-themes, and put together what we understood were patients' perspectives and doctors' perspectives of the treatment adherence. So when we ask patients what they know about diet, this is pretty much a range of what they say. And I'm going to read it so you understand the problems we have. Don't know what I can eat or I cannot eat. Can't eat any sugar or greasy food. I can eat everything but in moderation. I can only eat zucchini and other vegetables. They told me to eat a lot of fruit. They told me not to eat bananas, to eat watermelon, not to eat watermelon. They told me to have sugar once a day. I didn't know. So the confusion was such that nobody really had a clue. Very few of the women we talked to could say, oh, I know exactly what I can eat and what I cannot eat. And there was great confusion. When we presented this as part of the presentation to the doctors in the hospital, the doctors were holding their heads because they only have 5-10 minutes to meet with each patient. And they know that the patients often don't speak Spanish, or they speak Spanish as a second language and not very well. And of course, they know that they may not be understanding a lot, but it was clear that they weren't understanding much at all. So a patient would say, I think they should tell me all this step by step, right? Or a patient's husband says, nobody explained that to me. Maybe to my son, because sometimes he comes with my wife. My wife didn't speak Spanish. So disinformation, lack of information. The few times that the patients see a nutritionist, one nutritionist in a huge hospital, at times she wasn't in the hospital when we went, a patient says, she gave me a list of food, but it mostly includes things that are difficult to obtain, like powdered milk, tuna fish. They tell them to eat things that are not part of the Maya diet and that are expensive to get in the stores that are in the Maya communities. And then another woman said, she told me to eat anything but in moderation. And if you think about it, moderation can mean anything you want. I used to eat 20 bars of chocolate and now I only eat 3 or 4, right? So in this case, she said, well, if I eat 8 tortillas, now just eat 3. But moderation is not a very good concept to communicate, or we have to be more specific. With medicine and exams, the same kind of issue. I take the medicines if I have the money to buy them. I take the medicines if the doctor tells me, but when I feel better, I stop taking them. You know, for diabetes, you can't stop taking the drug that is prescribed. The most common one is metformin. They said you just have to take it the rest of your life. And people, because it's expensive, it's not an expensive drug, but it's expensive for people to buy. So they take it when they can. Sometimes we tell them to get one medicine, says the doctor, and the patient ends up bringing something else. What do the exams mean? Who knows, says one patient. Sometimes it's high, sometimes it's low, but they don't know what is that is high and what is that is low. How often you draw blood? we asked them, oh, we don't know, we didn't ask the doctor that. So again, great confusion, great lack of information about how to care for themselves. The same about communication, about exercise. They told me to walk half an hour a day. They told me to walk 2 hours a day. They told me to run. Where am I going to run? I mean, this is not part of the Maya practice to go out running. It's not like people in Ann Arbor that may go for a run. Maya people only run if the bus is leaving without them. Effective communication, we found 2 examples. This is what the doctor told me, says one patient, if you love yourself, if you raise your self-esteem, you have to take good care of yourself. And another one says that the doctor told her, there is God, there's your husband, but what is closer to you, that is your medicine. That is going to be your companion. A taxonomy of sources of motivation emerged from the interviews, and we organized them in 5 general categories: perceived advantages and disadvantages, self-efficacy, stigma, social images, norms, and emotions. So when we asked what were the perceived advantages and disadvantages of complying with the diet, people said, well, when I diet, I have more energy. I am hungry because I have to eat less than what they used to. I can't diet because if I eat so little, I cannot live. When I don't diet, I get sick. And when I cannot eat the same as other people, it's uncomfortable. These are examples that came up of self-efficacy. Yes, people thinking that they can do what they're expected to do with God's help, with help of their family, and so forth. Stigma, there's greatest stigma with people with diabetes. They're afraid that people may speak badly of them. We examine norms. People always offer food and you cannot say no. You know, you go to a party or to someone's house. My family wants me to eat with them. They don't like it if I eat something different than what they are eating. My husband thinks I'm dirty and that's why I have diabetes. The word in the community is that it's sexually transmitted, which of course it's not, but that's one of the many myths about the disease. And of course, all sort of emotions are associated to having diabetes. I'm sad when I think I have to be on this diet for the rest of my life. When I eat everything, I feel better, I feel happy. We asked people, women, how much they knew about the disease they had. This woman says, they say there are different kinds of diabetes. There is the chronic one. For that, there's no medicine. And there's the regular kind that comes with age and then it goes away. None of this is true. That's what she had constructed as an explanation of her disease. And I wonder, says another one, why the pancreas closes down, as if you had locked it and it cannot function anymore. What could one do to make it work again? Is it true that once it's closed, it isn't of no use any longer? So again, not enough information about their disease. It ends up that it is one that is hurting oneself, said a woman. Where's your self-esteem? I would tell myself. This is what she would tell herself so that she would stay on plan, on the diet and exercise, etc. I would recommend first to recognize that one is a diabetic, said a woman. Maybe love yourself a little more. So that's the important role of self-esteem. Gender and poverty, as I said earlier, are barriers to compliance. Poverty, of course, because they can't buy what they need to buy. The third example says, sometimes one is disobedient. I would love to sit at a table and drink fat-free milk. She's making fun of what nutritionists say, right? Drink fat-free milk, this kind of milk, those cereals, ham with fish and shrimp, eat well, but I cannot. It has nothing to do with their diet and with their possibilities. My husband gets mad at me, says a woman. Why so much medicine? He helped me twice to get the medications. That is why I wash clothes. So they're finding jobs on their own to pay for their medications. A woman talks about her daughters helping her. And another one says sometimes her husband brings medicines and her children. So doctors say we need health educators to educate patients. We need translators to address language barriers. We need more time. Well, they don't have health educators. There's not a single one in the hospital. There's no translators in the hospital. Sometimes one of the nurses who happens to be an indigenous Maya Quiche speaker will translate for someone else, but there's not that many of them. And more time, they just don't have more time in the hospitals. They're very resource poor. So doctors' recommendations are not things we could help them. We couldn't provide funds for, even if we had gotten a huge grant, we couldn't provide funds for more doctors or more time. And they do use this a medical hospital, so of course lots of medical students see patients. And the patient said, I want to be given written materials, graphic materials. I want them to help me to have more self-control. I want them to give me more information. I want the doctors to be patient with us. I want to be told the truth about insulin. They think that insulin will kill you because when patients arrive in the hospital after many years of being sick and they are told you have to be on insulin, sometimes they will die soon after because it's not enough. They're too past beyond the treatable or controllable situation. So they hear that patients take insulin and they die a few months later. So the word out there is that insulin will kill you. The truth is, insulin, if you start early enough, if you have especially type 1 diabetes and you need it and you start early enough, it's going to allow you to live a long, healthy life. But that's one of the myths. Okay, the big picture. So we had to come up with a framework, and based on this pilot study and all the information that we obtained from patients and from doctors. And we also had to come up with a plan, some kind of an intervention that it would not be costly, that it would be sustainable, because we would be there for a few months, but then hospitals have no money, patients are very poor. So it's not fair to tell them, well, you have to do this and that and this and that, and then leave, and they wouldn't be able to maintain those recommendations or those practices. The big picture was, in part, was influenced by Jim Jacquard's framework, communicate, motivate, facilitate, which has helped me organize the data that we collected, communicate clearly to patients what they need to do, motivate patients to do what they need to do by addressing their advantages and disadvantages, stigma, norms, self-efficacy, and emotions, and facilitate by making it as easy as possible for patients to do what they're motivated to do. And of course, ideally, we would remove barriers and provide social support. One way of providing social support is educating not just the patient, but the family, because there's such misunderstanding, and educate the community. So we decided to make videos. We decided to take advantage of the hours upon hours that patients sit in waiting rooms to see a doctor. And they will, when they see the doctor, they will see the doctor only for 5 or 10 minutes, where the doctor may diagnose them, say, okay, you have diabetes, you have to have diet, exercise, medications, and this, and everything. They don't have any written materials to give patients, so everything needs to be, I guess, memorized by the patients. So we decided to construct 5 different videos in both Spanish and, in this case, Maya Quiche, which is a language spoken in this particular town of Quetzaltenango. As I said, there's 22 languages spoken in Guatemala. And the videos had to be such that people would recognize themselves, not only their language, but their culture. The advice on diet had to be based on local diet and the local markets and what people can buy in the markets. Um, Everything about the videos had to be relatable to patients and doctors. Um, and let's see if I can find a mouse or is this, yeah, it's right here. I'm just going to show a couple of minutes of one of the videos. This is the video the spoken in Quiche. Well, you don't need more volume. The language is Quiche, so you want to understand, but the language is explaining. Trying to talk about the need to get out, to exercise, to walk as much as possible, to go to the hospital and take their medications. Trying to get to the, drink a lot of water. This is a wonderful woman that showed us how she exercises, how she takes the medication. When we were showing this video in a preliminary version of the video, one of the women that we invited to a focus group started crying. And so Elisa Liliana, who is fluent in Quiche, I speak some, but I'm not really fluent, went over to see what was wrong. And she said, it's the first time that anybody tells me in my language what I have and what I have to do. This is a 7-minute video where it talks about all the myths and all the problems and all what you need to eat and how much you need to eat and what's locally available. She's showing how you don't put any fat when you cook your chicken and so forth. So she was terribly moved by finally hearing in her own language. So that was really nice to see. She's showing that the chicken, they need to remove the skin, that it has too much fat. There's a lot of information here. We went to their markets. We showed them what not to eat. A lot of the Maya people are buying a lot of those sugary things that they get in, Fanta and cake and all this stuff. This is a lady that she said that she especially bought those pants and that shirt so she could exercise. And she's showing us how they showed her how to exercise, and she's great. And she loved that we were videotaping her. She wanted to do the entire show. Well, you can see. There's waiting them. For some reason, I'm having. Yeah. Um, yeah. Oops. Oh, yeah, yeah. Yeah, let me say it so that people can hear. So we installed, there's 2 waiting rooms. We installed very large screen TVs, and we put the videos, 7 videos. One is entirely in Quiché, the others are in Spanish, divided by diet, exercise, all the care of the feet, which is a very serious problem since many women walk barefoot or walk with sandals, and they get a lot of infections in their feet. And so they're constantly in the waiting room. So it's not just going to the patient, the diabetes patient, it's going to the people that are there for hours that will go home and they'll have someone they know that has diabetes. So it's aimed at going to the communities and families and so forth. Of course, first if I can get to where I was, which I shouldn't have. Um, be patient with me. We're almost done. So we show the videos first in focus groups. This is the main endocrinologist in the hospital. He referred to this, the intervention, which is the videos and brochures. I'll show you the brochures in a moment, as historic, because he never saw anything in the language, in the style, in the completely culturally appropriate for the population. There's when the focus group is watching the video. And these are the brochures that the doctors really wanted so that they can give patients to take home and look at them. There's 4 different brochures. They have to do, again, with diet, exercise, medications, and care of the feet. All the drawings are appropriate for the community. We also teach them, if they need insulin, how to take the insulin shot, what kind of shoes to wear, how to dry their feet, how to walk, how to check their feet with a mirror to make sure they didn't hurt their feet, the kind of food they can eat. So this was also a good hit. And to conclude, adherence is impacted by lack of information, the presence of myths and lack of support, combined with issues of poverty and gender subordination. Women who have difficulties adhering to protocols doubt their doctor's recommendations, hear different perspectives from others, are criticized by their husbands, suffer stress due to different interpretive frameworks. I didn't mention, of course, that we did a small evaluation of the videos. We did a 2-group evaluation, and we were pleasantly found that focusing on diet and exercise, that the people that have seen the videos told us that they had begun exercising and that they were being careful with their diets. They now understood what it was expected of them. We are trying to get money to do a dissemination. We have 13 hospitals in Guatemala that have agreed to participate with us to allow us to reach their patients with diabetes, so that we can construct cultural, as I mentioned, there are different languages, and each region of Guatemala has different foods and different local particularities. So the videos have to be done with focus to the region. So we are hoping to get money to do the dissemination. Just if this is a framework that we feel confident that addresses communication, motivation, and facilitation in culturally sensitive ways. and it should be useful not only in Guatemala, but in other places where there's cultural differences. And when we looked and we did try to identify all the programs for diabetes in other Central American countries, they're always focused on urban areas and levels of education that are higher than the 4 years. And to be honest, difficult to follow and understand. I can't go to the next slide. If you have any questions, I'll be happy to answer. Yes. No, we show in the hospital constantly 5 videos. One is a general, the one that you saw is all in Quiché Maya and addresses all the areas of care, and myth is the longest one, which the Maya speakers prefer. And the others are, one focuses on diet, one focuses on exercise, and one focuses on myths. Because there's so many myths. People, we need to tell men to stop harassing their wives if they have diabetes, that there's nothing to do with sex and that they need to help. We also tell them that it'd be good if the whole family eats like the diabetic patient, because the diabetic patient eats healthy food, less fat, lighter food. They need to eat a healthy diet. And so that it wouldn't be eating like a sick person, it would be eating a healthy diet for the entire family. So we point that out, that would be good, a variety of vegetables and a variety of proteins. And very little sugar, although we don't tell them to eliminate sugar completely, but that it has to be very little, and they need to think about the foods that already have sugar in it, like corn. And corn is part of their basic diet, of course, so they have that's why tortillas are a problem if they eat so many. But when I said there's 22 languages, throughout Guatemala, there's 22 Maya languages. So if I move a few hundred kilometers to the right, I will have to write, the video would have to be in Cachiquel and not in Quiché. And the foods are going, not 200 kilometers won't be that different, but when we go to the northeast of Guatemala, where you have the jungles and forests, the food is different. There's a lot more fruits and a lot more fish, and there's different food. Yeah. Yeah. We have what I call my team, the people I work with. Most of them are in Guatemala City, except for Liliana Schiap, who is a doctor in the Western Highlands. So she and my team have been contacting them often to see if the videos are working, if they need more brochures, because we told them we'll be reproducing the brochures as long as they need them, because we're afraid that they might, once they run out of brochures, they might not want to spend the money to make the copies. So yeah, we're in touch with them. On one of our calls, they found that the patients had turned the channel on the TV to watch soccer. And so we got the technicians that installed the 2 TVs in the waiting rooms to block the possibility of changing the channel. Obviously, people are waiting, and some of them probably thought, I already watched this, I want to watch something else. But so yeah, we need to keep an eye, because we feel that if we never contacted them again, although the doctors love those videos and they love the brochures, the doctors, when they diagnose someone with diabetes, the first thing they tell them is go to the waiting room and watch all the videos from beginning to end, because that's going to explain to you better than what I can here in. The videos are reaching hundreds and thousands of people, and we think if we can disseminate, it's going to reach families, are going to reach a lot more than we could possibly do if we go house by house with little diabetes training, which is what some people do. They do diabetes training in clinics, or I think that it's one inexpensive way of reaching a large population. You had an, yeah, sure. Yeah, she was named after me. That's why I'm bragging. Yeah, yeah. This is not a community-based intervention, so that it's the people that go to the hospital. A lot more would have to be done. My group in Guatemala City know that if any local clinic would like the videos, and we don't have money right now to put screens everywhere, but we can make copies of the videos for anybody that wants them, and we're starting to do that, to let small clinics or places that might want to show them get a copy of the video. They would have to get a TV screen, but it's not a community, so she wouldn't. Oh, okay. Look, we can guarantee that the people that are sitting there for 4 hours with the videos going on are paying attention for 4 hours. But if they pay attention for the 7 minutes that last one video, is some information that they're getting. In the small evaluation that we did, they were getting information. So, and people had seen the videos more than once. They have to go back to the hospital for testing, for blood tests and so forth. But no, we cannot guarantee that there will be everybody be super attentive, but we are expecting. There's music in the videos, there's people like themselves, there's people they know, because these are people from the community that agreed to let us go to their houses and show how they cook. So there's also comments, that people would make, that they recognize someone. But that is the, how should I call it? We can't guarantee how effective it's going to be for everyone, but we think that this is going to be filtering. We hope this is going to be filtering to the rest of the community. Yes. Right. No, for that we need more money, and we are talking about doing a bigger study if we can get also a bigger evaluation, because the one we did was small. But we also would like to know a year later, 2 years later, if they have less patients with diabetes in the hospital, but yeah, we don't have that kind of data yet. But of course, it would be nice to get that. Yes. That is available. There's markets 1 day a week in most communities. That was my dissertation topic, the markets of Western Guatemala. And they're 1 day a week. People come from the whole region and bring their best fruits and vegetables and animals. The San Francisco El Alto, which I mentioned earlier, is an animal market where people bring all sort of the strangest animals that people will, the regular kinds that we would buy, but others as well. And so the rest of the week, if they haven't bought on market day, they may not find the good fruits and vegetables unless they go to Quetzaltenango, which for many of them is 90 minutes, an hour, 2 hours, right? But within Quetzaltenango, there's a permanent market where you can buy all of that. In the towns, it's 1 day a week. The rest of the week is tricky because they buy the sodas and they buy the chips and they buy all the crappy stuff that is really bad for them. But of course, that's one of the things we tell them. They need to plan their meals, right? They need to know what they're going to need for the week. But the vegetables in Almolonga specializes in vegetables. The size of the vegetables in Almolonga, in part because they use tons of fertilizers, are like, an apple will be this. It's just ridiculous. Yeah. Yes. Thank you. Yes. Yeah. That's the life of indigenous peoples in so many countries of the world, where some colonizer moved in and all the good services are provided in a language that they often they may speak, because of course the young people are going to school and they're learning Spanish in school. So the youngest, sometimes parents will say, I go home and now I can show the brochure to my 8-year-old daughter and she reads it for me. So that the younger people are going to school and they're much more fluent in Spanish, although the family speaks in a Maya language. But this um, uh, situation with service providers, all we can wait is that there be more doctors, indigenous doctors, and there are more. In more communities start sending more young people to study medicine. And when I talked to the medical students in the hospital, and some of them were indigenous peoples getting their medical degrees. So that is going to bring better communication. The more we educate, the more indigenous peoples are educated in higher education. But for now, yes, it is, they go in, the nurses and doctors will speak Spanish. The patients know to bring either a husband, a son, a daughter that will help them understand, or the nurses, we observe how the nurses were showing um, how to care for the feet. So they were being very visual because they knew that the person wasn't understanding well. So she would take a pair of scissors that has a special ending to cut your nails so you don't hurt yourself. And it was all done in very visually trying to communicate better. But the truth is that uh, what the doctors say they need, translators, more time. Yeah, they need that. And that is something that probably the state will have to keep, obviously there's state efforts to improve medical services, but Guatemala is one of the worst in Latin America. There's no insurance at all. There's no, people are really on their own as far as providing. So it's very stratified. If you have some money, you go to a private hospital and you get better care. And if not, you do what you can. Yes. Most, yeah, most people have mobile phones, but they're the ones who used to, there's not a lot of information that you can pass, but they are used for lots of things, right? People use them for banking and lots of things. We try to think about different ways in which you can communicate. We thought of schools, of course. That's one place where uh, if you educate children about the care, children go home and they're great to tell their parents, no, what you're eating is wrong, or what you're. So we did think of school-based programs. There's yeah. Mhm. Yes. Yes. In fact, in one of the earliest grants that I wrote, there was a whole community health delivery component, but it was making the proposal extremely expensive because we had to first bring people from the communities to train and then send them back. But we also had to have some way of reimbursing them at some point, and we didn't know how to make that sustainable because we could see them if we said, we'll find a way of reimbursing you at the beginning, but we couldn't be sending money throughout Guatemala. So it became just a little out of hand. You remember, Jim, one of the first proposals that I write had a whole community health delivery component. Right. They're good programs, but they're hard to sustain.